Hello again. My name is Dr. Michelle Johnston from Royal Perth Hospital, one of the emergency physicians, and this is 5 on Friday. So today's topic, we're going to have oxygen, the Jekyll and Hyde of oxygen, the evils of oxygen. Now, we critical care folk, we're sort of a fickle bunch, really. For such a long time, we've told everybody, give fluids, give oxygen, trust no one. And over recent years, we've discovered those first two need to be thrown completely out, and we're just left with the last, which is kind of a good thing in this pre-apocalyptic, post-factual world we find ourselves in. But anyway, oxygen. There is no question that not having enough oxygen is bad for a body. But what about this other side, too much oxygen? Well, let's just have a few moments to talk about some of the pathophysiological reasons why giving too much oxygen to people is also detrimental to their outcomes and well-being. So we can look at a couple of different. The interesting thing about oxygen is it's different requirements for different people and different pathologies. So some of the pathologies that do badly with too much oxygen are, well, let's look at about 4 things. The neonate, we've long known about what happens with too much oxygen, destroying retinas and their lungs. We're not going to go into that. That's not really as relevant to us today. COPD patients. Now, you all would have probably heard the axiom that giving oxygen to these patients causes them to knock off their hypoxic drive. Well, that's probably not quite true. Really, giving oxygen to these patients probably has a much more complicated effect on their CO2 levels, including things like oxygen causing sudden pulmonary vasodilatation and increasing their shunt. Also, there's a bit of jiggery-pokery that goes on with hemoglobin, the Haldane effect with displacing CO2, causing the CO2 to rise. And also, we know that you give too much oxygen to those patients, they have something called denitrogenation and absorption atelectasis, also causing the CO2 to rise. If your CO2 rises, you knock off your respiratory drive and you can become more hypoxic, causing a vicious cycle. So we know that giving too much oxygen is not good for these patients. Our aim for those patients is to target a saturation of anywhere between 88 and 92%, not much more than 92%. But what's really become interesting recently is in local ischemic events such as coronary ischemia, myocardial infarctions and strokes. We now understand that giving oxygen when it's not required is not good for those patients either. The pathology for that is probably different again, and it relates to the circulation in a reperfusing state of oxygen-free radicals, which cause significant cellular damage. And also you can get abnormal vasoconstriction in the peripheries as well, which also can worsen the ischemic effect. Some data suggests that giving oxygen when it's not required and giving superoxygenation can increase the infarct size in a myocardial infarction. So the data is now telling us that we should not be routinely giving these patients oxygen. What we want is for patients to be sitting with the saturations around 92 to 96%. We should be happy with that and therefore not giving oxygen unless the patient is hypoxic. For our definition, hypoxia relates to saturations of about 90% or below. That's when we hit that slippery slope of the oxygen dissociation curve and their PO2, which is not what we're measuring in the field and certainly not what we're measuring when they first hit the ED. That's when it's going down through into its boots. I'm not sure whose boots, the oxygen's boots. The fourth pathology group, if you like, and this is where the data is becoming really interesting. Very early days, but we know that patients who are in a systemic ischemic state, patients who are post-cardiac arrest, intubated patients post-head injury, post-severe trauma, we're not talking lung trauma, if we're talking a really disrupted pathophysiology, we know that they too do much worse if they have a high PO2. Now remember, PO2 very different than SATs. Just to separate them out, if those patients have a PO2 of anywhere above 2 to 300, we know they have a worse outcome. So our job in those patients is to find that Goldilocks zone, not too much, not too little. Now, that's a more complicated translation to what you see on a SATS probe, because your SATS of 100% could mean anything from a PO2 of 100, which is excellent, to a PO2 of over 300, which is no longer excellent. So certainly in the emergency department, we look at starting to decrease the patient's FiO2 so that the saturations just drops down below 100. Not too much more, because these are critically unwell patients, and we know hypoxia is worse for a patient than hyperoxia. But we're going to try and find that, as I said, Goldilocks, just right zone. Now, I've talked quite a bit about the SATS probe, the SATS monitor. The SATS probe is your friend. It should be your friend. It should be your very dear friend. In fact, it really should be another one of the vital signs, the saturation. So if you're going to use tools like this, you want to be very clear that you understand the utility and the limitations of using these, using a SATS monitor. Obviously, we're measuring the saturation of the hemoglobin's oxygenation in the blood. So to get a good and accurate reading, which is what you want, you need to make sure that you are looking at a good waveform trace. You can't trust a number that is given to you by the machine if the trace doesn't look like a pulsatile waveform. So when you get that pulsatile waveform, then you can trust that number. How do you get a good pulsatile waveform? Well, there are reasons why you're just not going to be able to get in some patients. If patients are hypoperfused, they do not have enough pulse pressure between systolic and diastolic pressure, you will not get a good trace. Movement artifact will also disrupt your ability to get a good tracing. Nail polish, skin pigmentation, ambient light also can affect your oxygen saturation. The other thing, the SATS machine, it's like a little time machine. It's not really the sort of time machine that I would like, which would take me back to seeing pterodactyls flying overhead, or perhaps watching Shakespeare performing one of his own plays at the Globe Theatre. But no, what it does, it actually looks back into the past. It looks back into the past 1 to 2 minutes. So what you're seeing, that number that you're seeing, that saturation, is reflective of what happened 1 to 2 minutes ago. So it's really important when you use the SATS monitor that you are also, you don't rely on that solely, you're also watching respiratory rate, colour, cerebral perfusion, all that sort of thing. It's all put together. As we know, critically ill patients are nuanced. So in summary, what we can get out of this is that, yes, that too much oxygen is bad, but not as bad as too little oxygen. If you had to take anything away from this, still oxygen is a vitally important part of managing critically unwell patients, as long as they need it. The deal is to tailor your oxygen therapy to the disease process that's in front of you. Sometimes it can be difficult. We don't sometimes know early on in the ED what the problem is. But you can never go too wrong if you think, I want to keep my saturations around the 92 to 94% mark. And that should steer you in good stead. I have a great story about Jekyll and Hyde, but we don't have time. I can't tell you today, so maybe they'll keep that for another time. Thank you.